My doctor thought I was being dramatic about the pain, so I ended up in emergency surgery 3 days later. The surgeon who saved my life introduced himself at 2:19 a.m. on a Thursday while I was being wheeled through the double doors of Cresthaven Medical Center's OR prep unit, and the first thing he said to me, before his name, before any reassurance, before anything procedurally appropriate, was, "Who was the physician who sent you home?" I told him. He made a sound that I would later describe to my attorney as clearly recognizable displeasure, but that in the moment I was too close to losing consciousness to fully process. His name was Dr. Yemi Falaid, attending surgeon, 15 years of practice, the kind of man whose calm in a crisis communicates itself through the quality of his stillness rather than anything he says. He told me I had a perforated appendix, that I was septic, and that without surgery in the next 2 hours the infection would reach a point of no return. Then he looked at the notes from my emergency department visit 3 days earlier, the one where I'd been sent home with a diagnosis of muscle strain and a prescription for ibuprofen, and something in his face changed in a way I couldn't fully read, but that made my husband Declan, standing beside the gurney gripping my hand, go very pale. "We're going in now," Dr. Falaid said. That was it. No more questions. They took me into surgery, and I thought, with the specific clarity that arrives when your body is failing and your mind is still running, that I had been right all along, and that being right had almost killed me. I'd been dealing with pain in my lower right abdomen for 4 days before I went to the ER the first time. That timeline matters, so I want to be clear about it. 4 days of escalating discomfort? Not the vague and generalized kind that you might attribute to diet or stress or the 1,000 small complaints of body issues over a lifetime, but a specific localized pressure that worsened with movement and didn't respond to anything I took for it. I was 34 years old, a high school history teacher in my 9th year of teaching at Alderton Preparatory in Chicago, healthy by any reasonable measure, a person who ran 3 miles twice a week and had never had a surgery in her life. And I mention this not to establish some hierarchy of suffering, but because it's relevant. I knew my body. I had a baseline, and what I was experiencing over those 4 days was not within my baseline in any way I could rationalize. The pain started on a Sunday, mild enough that I told Declan it was probably something I'd eaten. By Monday, it had a sharpness to it that made me favor my right side when I walked. By the time I called in a substitute for my classes on Wednesday morning and drove myself to the ER, I had a low fever of 99.8 degrees. I couldn't stand fully upright without the pain sharpening, and the area under my right hip was tender enough that even the waistband of my pants sitting against it made me wince. I drove to Millbrook General Hospital at 10:15 a.m. on that Wednesday, and I told the triage nurse very specifically that I had right lower quadrant pain that had been worsening for 4 days, that I had a low-grade fever, and that I was concerned it might be my appendix. The waiting room at Millbrook General was the kind of fluorescent-lit purgatory that erodes certainty. You sit there long enough and you start wondering whether the thing that sent you there was really as serious as you thought when you were standing in your kitchen at home. I waited for 2 hours and 40 minutes. My fever climbed to 100.1 during that window, which I know because I had a travel thermometer in my bag that I checked twice. By the time a nurse took me back and did initial vitals, I was rating my pain at a 7, and the number felt conservative. I was placed in an exam bay and told the doctor would be in shortly. Shortly turned out to be 45 minutes. The physician who came in was Dr. Conrad Halsey, and I want to describe him accurately because accuracy matters. He was in his early 50s, competent-looking in the way that can read his confidence from a distance and condescension up close, and he came into the room already reading something on his tablet, already slightly distracted. He asked me where the pain was, and I pointed to my right lower quadrant. He pressed on it, one hand, brief pressure, and I gasped and grabbed the side of the exam table. He made a note. He asked if I was under stress. I told him I was a teacher in my 9th month of school. He asked if I'd had any recent changes in diet or exercise. I told him the pain had started 4 days ago and had been getting worse. He asked if I was sure about the location. I said yes, I was sure. I'd been living in my body for 34 years, and the pain was in my lower right abdomen, and it had been there for 4 days, and I had a fever, and I was worried about my appendix. He looked at me in the way that certain physicians look at patients who have come in having done research. Not quite dismissive, but adjacent to it. The look of someone who has decided that a patient naming a diagnosis is more likely to be anxious than accurate. He said he was going to order some blood work, and we would go from there. The blood work came back showing a white blood cell count of 12,400, which is elevated. Normal range is 4,500 to 11,000. I know this because I looked it up on my phone while I waited, and I know what the number means because when Dr. Halsey returned to my room 30 minutes later, he mentioned it in a way that I can only describe as strategically minimized. He said my WBC was slightly elevated, which was technically accurate and contextually misleading, and that this could indicate a mild infection or could simply be a stress response. He said my abdomen was soft on examination. He pressed 4 points in under a minute, which I timed, and that he did not believe I had appendicitis. He said he thought the most likely explanation was a muscular strain, possibly related to my exercise routine, combined with a gastrointestinal irritation that was causing referred pain. He said the fever was consistent with a mild viral process. He prescribed 800 milligrams ibuprofen, told me to rest, told me to return if my fever went above 102, or if the pain became significantly worse, and sent me home. I sat on the edge of that exam table after he left, and I felt the specific combination of relief and doubt that arrives when an authority figure tells you you're fine and your body is simultaneously telling you something different. I got dressed slowly because bending forward to pull on my shoes sent a flare through my right side. I drove home, I took the ibuprofen, and I told Declan what the doctor had said, and he looked relieved, and I tried to feel relieved too, and mostly I just felt tired and still in pain. The second day at home was worse. I want to be precise. Not dramatically, cinematically worse, in a way that would have sent any reasonable person sprinting back to the hospital, but steadily, undeniably worse in the way that a tide comes in. The fever went to 100.6 by the afternoon. The pain had moved from a localized pressure to something that radiated, spreading a tightness across my lower abdomen that made deep breathing uncomfortable. I ate half a bowl of soup for dinner and felt nauseated afterward. Declan wanted to go back to the ER, and I told him I was following doctor's orders, that I'd been told to return if the fever hit 102, and it hadn't hit 102 yet. I was rule following in the way that people follow rules when the rules feel safer than their own judgment. Okay, when an authority has spoken and the authority was convincing enough in the moment that undermining him feels like self-indulgence. I took the ibuprofen every 8 hours exactly as prescribed. I slept badly, waking twice when I shifted position in a way that sent pain flaring. By 6 a.m. Thursday, I was lying in bed running through a mental checklist that I didn't fully acknowledge was a checklist. Fever still below 102. Pain worse, but not dramatically worse. Instructions said to return if significantly worse. Is this significantly worse? Define significantly. I made coffee. I didn't drink it. The smell made my stomach turn. My colleague Brigitte called me at 8:30 Thursday morning to check in. Brigitte Holst had taught English at Alderton for 12 years, was one of my closest friends, and had been a surgical ICU nurse for 4 years before she transitioned to teaching, which is a detail that becomes important. I told her how I was feeling. She asked me to describe the pain pattern over the last 24 hours. I did. She was quiet for a moment, then she said, "Miriam, the pain radiating to the entire lower abdomen after starting in the right lower quadrant, combined with the fever and the nausea, is a pattern I've seen before, in my nursing years. I need you to go back to the ER." I told her the doctor had said it was muscular strain. She said, "I know what the doctor said. I'm telling you what I know. Please go." I got off the phone and sat at the kitchen table and looked at my hands, which were steady, and thought about the fact that a former surgical ICU nurse was telling me to go back, and a board-certified physician had told me I was fine, and tried to decide which voice carried more weight in my specific situation. I called Declan. He was at his firm. He was a civil engineer an hour from home. He said he was leaving immediately. I said I'd wait for him. He said no, go now. He'd meet me there. I picked up my bag and my car keys and I drove back to the ER, and I want to acknowledge here that decision, made at 8:47 a.m. on a Thursday, is the reason I'm alive to tell this story. Millbrook General's ER was less crowded than it had been on the previous visit. I was triaged within 20 minutes. My vital signs this time showed a fever of 100.9 and a heart rate of 102, elevated but not alarmingly so. A nurse named Claudette Obi, who had been in emergency nursing for 11 years and who I later thought of as the first person in that building who fully heard me, pressed gently on my abdomen during triage, noted that I flinched and drew breath sharply, and documented guarding, the involuntary muscle tension that happens when your body is protecting an area from touch. She asked if I'd been here recently. I told her yes, 2 days ago, and that I'd been sent home with a muscle strain diagnosis. She typed something in the system without changing her expression, but something in the quality of her attention shifted in a way I registered without fully understanding yet. She told me a physician would be with me shortly and that she was flagging the chart. I went to an exam bay. Declan arrived 16 minutes later, still in his work clothes, having broken enough traffic laws to make good time. He sat in the chair beside my gurney and held my hand, and I could tell from the way he was looking at me that the way I looked scared him more than anything I'd said on the phone. I hadn't seen my own face since morning. I didn't ask for a mirror. The physician who came in this time was not Dr. Halsey. Her name was Dr. Priya Kurian, a third-year emergency medicine resident, 29 years old, and she came in with the focused attention of someone who had read the chart before entering the room. She asked me to describe the pain in my own words from the beginning. I told her everything: the Sunday onset, the 4 days of escalation, the Wednesday visit, the diagnosis, the way the pain had changed since then. She listened without interrupting, which sounds like a small thing and is not a small thing. She palpated my abdomen carefully, with more points of pressure and more precision than the previous examination. And when she pressed on a specific point in my right lower quadrant and then released quickly, the rebound pain made me cry out, which I hadn't done at any point in the previous 2 days. Rebound tenderness, pain that is worse when the examining pressure is released than when it's applied, is a classic sign of peritoneal irritation, which is what happens when an inflamed appendix begins to leak or rupture. Dr. Kurian told me she was ordering a CT scan of my abdomen and pelvis with contrast, a complete blood panel, and a urine analysis, and that she was not comfortable sending me home without imaging given my presentation and the fact that this was my second visit in 72 hours with worsening symptoms. She said it calmly and matter-of-factly, as if this were simply the obvious next step, which it was, and which it had been 2 days earlier and which had not been taken 2 days earlier. I looked at Declan. He was staring at the floor. The blood results came back in 40 minutes. White blood cell count, 18,600. In 2 days, my WBC had gone from 12,400 to 18,600, a trajectory that tells a story about an infection not being treated and not resolving and not being muscular strain. Dr. Kurian came back in before the CT results, showed me the number, told me what it meant in plain language. She said her clinical suspicion was high for appendicitis and that the CT would help them understand the extent of the inflammation. She also said, looking at me directly in a way that communicated she wanted me to hear this clearly, "Based on what you're describing and what I'm seeing, you should have had imaging on your first visit. I'm not saying this to assign blame right now. I'm saying it so you understand that coming back was the right decision, and I'm glad you did." I pressed my lips together. Declan's jaw was working in the way it does when he's controlling something. The CT went quickly. The contrast dye, spreading that familiar warmth through my chest during the injection. I lay very still in the scanner and stared at the ceiling and breathed as shallowly as I could, because deep breaths were pulling at something that felt like it was losing its structural integrity. 20 minutes later, Dr. Kurian was back with Dr. Fillet, the attending surgeon, and they were both looking at images on a tablet. And the quality of the silence between them before they looked up at me was a sentence all by itself. The CT had found a perforated appendix, ruptured, with a contained abscess in the right lower quadrant and early signs of spreading infection in the peritoneal cavity. Perforation, sepsis beginning. The technical language arrived in a stream, and I understood each word, and the combination of them together produced a physical response in me that was not panic but its opposite. A specific cold clarity, the kind your nervous system delivers when it understands that the time for ambiguity is over. Dr. Filat explained what was happening and what needed to happen with the economy of someone for whom clarity is a form of care. The appendix had perforated, likely in the last 18 to 24 hours based on the imaging, he said, though he was careful about exact timelines. The abscess was contained for now, but the infection was spreading. They needed to operate. He went through the risks of the surgery and the significantly greater risks of not operating, and I signed the consent forms while Declan held my hand and didn't say anything, because there was nothing to say. Dr. Falad reviewed my chart from the Wednesday visit before they took me to prep. He read it fully. That was when he asked me who the physician had been, and I told him, and he made the sound I described earlier, and then we were moving. Surgery took 3 hours and 12 minutes. Because I know because Declan tracked it from the moment the OR doors closed, sitting in the surgical waiting area with his phone in his hand and his sister Noelle beside him, who had driven from Evanston at 11 p.m. after he'd called her. The surgeon removed the perforated appendix, drained the abscess, irrigated the peritoneal cavity extensively to clear the infection, and placed a temporary drain. When I woke up in the recovery room, the first sensation was pressure across my lower abdomen, the specific packed gauze heaviness of a wound area, followed by a thirst so acute it was almost its own category of pain. A recovery nurse gave me ice chips. The surgical resident on call, Dr. Amara Nwosu, 2 years into her residency and the kind of young physician who explains things clearly because she hasn't yet learned to assume patients don't need to understand, came to tell me the surgery had gone well, that they'd gotten clean margins on the drainage, and that I was looking at 3 to 5 days inpatient followed by 4 to 6 weeks of recovery with ongoing monitoring for infection. She said Dr. Filade would see me in the morning. She asked if I had any questions. I asked if I would have needed the surgery if I'd been correctly diagnosed 2 days earlier. She looked at the chart. She looked at me. She said, "That's something Dr. Filade will want to discuss with you." Which was an answer. I spent 4 days in the hospital. I want to be honest about what those 4 days were like because sanitizing them would misrepresent what happens when your body has been through something it shouldn't have had to go through. The drain in my side was uncomfortable in a way that's difficult to describe. Not exactly painful, but persistently wrong. A reminder every time I moved of the infection that had been growing untreated while I was following instructions to go home and rest. My fever spiked to 102.4 on the second inpatient night, which required adjusting my IV antibiotics, and the night nurse, a man named Theodore Graves, who had been doing hospital nursing for 8 years and who I found genuinely kind in the way of people who have chosen a hard profession and are still doing it well, sat with me for 20 minutes at 3 a.m. while the fever peaked, and I was afraid, just quietly present and professional, taking my temperature every 15 minutes and talking about nothing in particular because silence at 3 a.m. in a hospital room is a different quality of silence than silence anywhere else. Declan was there every day during visiting hours. My mother drove down from Milwaukee on the second day and cried when she saw the drain, and then collected herself and brought me 3 types of soup she'd made at home, which I couldn't eat yet, but which I kept on the bedside table because the containers felt like something solid. My students sent a card which the department secretary had passed around the faculty room first, so the signatures at the bottom were 73 names long. I cried at that too, privately, when Declan had gone to get coffee. Dr. Flade met with me formally on the second inpatient morning, sitting in the chair beside my bed in his white coat, and he talked to me about the case with a directness I had come to understand was characteristic of him. He said that based on my imaging and the surgical findings, the appendix had been in the process of rupturing for at least 24 to 36 hours before I arrived at the ER the second time, and had likely been severely inflamed for 48 to 72 hours before that. He said the absence of imaging on my first visit had been, in his professional assessment, a departure from standard practice given my presentation: right lower quadrant pain, fever, elevated WBC, prior duration of symptoms. He said it carefully and without dramatics, in the language of a physician who understood he was speaking about a colleague, but who also understood that what he was saying was true, and that I deserved to hear it said clearly. He said he would be documenting his assessment in the medical record as part of standard surgical notes. I asked him what I should do with that information. He said, "That's not something I can advise you on, but I will tell you that what happened to you was serious, and you have every right to understand why it happened." Then he stood up, checked my drain, told me the overnight nurse had noted my fever was trending down, and told me he would see me again tomorrow. I looked at the ceiling after he left and thought about that. Every right to understand why it happened? My sister-in-law, Noelle, was the one who suggested the attorney. Noelle Abernathy worked in healthcare administration and had enough institutional knowledge to understand what I was dealing with faster than most people would. She gave me the name of a woman named Diane Chukwu, who had been practicing medical malpractice law in Illinois for 19 years, who had tried 38 jury trials and had a reputation in the field for being exceptionally thorough in the pre-litigation documentation phase. I called Diane's office from the hospital on my third day, which I've mentioned because I want to be clear that I did not make this decision in the heat of fear or anger. I made it 3 days into an inpatient stay that had started with emergency surgery for a complication that should have been caught, lying in a hospital bed with a drain in my side and a fever that kept returning, and I made it calmly and with the specific precision of someone who has had a lot of time in a quiet room to think about what she was told and what she was not told, and what the difference between those two things cost her. Diane came to meet me at the hospital on my fourth and final inpatient day, the day before discharge, carrying a legal pad and the particular focused attention of a professional who has heard many versions of this type of story and is already assessing which elements of this one are legally actionable. She asked me to walk her through everything from the first symptom to the current moment. I talked for 40 minutes. She took 3 pages of notes. At the end, she said, "This case has merit. The question is how much?" I told her I wasn't doing it for money. She said, "Good. But money is how the system communicates what happened was wrong, so we'll pursue both." The documentation phase that followed took 4 months. I want to describe it accurately because people who haven't been through a malpractice process often imagine it as a single dramatic confrontation. And it is nothing like that. It is painstaking and slow and requires a tolerance for detail that I had because of my professional life, but that I can imagine would exhaust someone else. Diane subpoenaed my complete medical records from Millbrook General for both visits. She retained a medical expert, a board-certified emergency medicine physician named Dr. Kwame Opong, who had 22 years of practice and had served as a peer reviewer for emergency medicine quality assurance programs, to evaluate whether my care on the first visit had met the applicable standard. Dr. Opong reviewed every page of the record, including Dr. Halsey's documentation of the first visit. His written opinion, which Diane shared with me as Exhibit C in the case file, was 41 pages long and concluded, in the precise and measured language of expert medical testimony, that the failure to order abdominal imaging, specifically CT or ultrasound, for a 34-year-old patient presenting with 4 days of right lower quadrant pain, low-grade fever, and an elevated white blood cell count represented a departure from the standard of care in emergency medicine. He noted that the Alvarado score, a clinical scoring tool used to assess appendicitis risk, would have placed me in the moderate to high-risk category based on my documented symptoms, and that clinical guidelines recommend imaging for patients in that category. He noted that Dr. Halsey's examination documentation described a 4-point abdominal palpation that took less than 2 minutes, which was insufficient for a thorough assessment of the right lower quadrant. He noted that the discharge diagnosis of muscular strain was not supported by the clinical findings documented in the chart. He concluded that with timely diagnosis and treatment, the perforation and its complications were very likely preventable. I read Dr. Opong's report twice. Then I set it down and sat at my kitchen table in the particular stillness of someone who has just seen their experience of something terrible converted into institutional language and confirmed as real. There is something strange about having your suffering validated in a 41-page document. It's not satisfying in any simple way, because validation 4 months after the fact doesn't unmake what happened. But it does something else, something important. It makes the thing undeniable. Not just to a jury or a judge or an insurance company, but to the small voice that had been asking, somewhere underneath everything, whether the doctor had been right and I had been dramatic. He hadn't been. Or I hadn't been. The numbers in the imaging in the 41 pages said so. I called Diane and told her I'd read it. She said, "Now we send the demand letter." The demand letter to Millbrook General and to Dr. Halsey's medical liability insurer was sent on a Thursday in late October, outlining the facts of the case, the expert findings, and the damages. Medical expenses totaling $94,000, 4 weeks of lost wages at my teacher's salary, the cost of in-home care during my recovery, ongoing medical monitoring costs, and a claim for pain and suffering that Diane said she would argue based on the nature of the complication and the length of recovery. The letter gave the defendants 30 days to respond. The response came in 22 days through the hospital's legal team and Dr. Halsey's insurer, and it was what Diane had predicted. An offer that was substantially below what she'd argued the case was worth, designed to test whether we would take an early number and go away quietly. We declined. Diane filed the lawsuit in Cook County Circuit Court. This is where things moved faster than I'd expected, because the hospital's discovery process revealed something that had not been in my individual chart. Dr. Halsey had, in the preceding 18 months, been the subject of 3 internal incident reports from the Millbrook General Quality Improvement Committee, all of which involved patients who had presented with abdominal pain and had been discharged without imaging and subsequently readmitted. None of the 3 prior cases had been as serious as mine, none had resulted in surgery, but the pattern was documented and internal, and the fact that the hospital had this information and had not adjusted Dr. Halsey's practice privileges was a discovery that changed the shape of the case significantly. Diane called it institutional knowledge of a pattern, which is legal language for the hospital knew and did nothing, and now a patient had been seriously harmed. I sat in Diane's office when she told me about the prior reports and felt the specific cold anger that comes not from a single person's failure, but from a system's decision to absorb individual failures rather than correct them. 3 other patients. Before me. The case did not go to trial. Settlement negotiations began 6 weeks after the lawsuit was filed, with the hospital and Dr. Halsey's insurer both represented, and they were conducted through Diane on my side and a team of 3 attorneys on theirs. I was not in the room for most of it, which is how civil litigation works. Your attorney negotiates, you receive updates, you make decisions about numbers and terms, and you try to remain clear-eyed about what you actually want, rather than letting the process become about winning in a way that loses sight of why you started. What I wanted was acknowledgement that what happened was wrong, changes that would prevent it happening to the next patient, and compensation that reflected the cost of what I'd been through. Diane was direct with me about which of those 3 things the settlement process was capable of delivering and to what degree. The settlement we reached after 9 weeks of negotiation included $385,000 in damages, which I want to be clear about. Not a number that made me whole, because there is no number that makes you whole, but a number that the legal system produced as its accounting of what had happened and what it cost me. As a condition of the settlement, Millbrook General agreed to implement a mandatory imaging protocol for patients presenting with abdominal pain and elevated WBC who had been symptomatic for more than 48 hours. A protocol change that Diane negotiated specifically, in writing, as a non-negotiable term, and that will apply to every patient who walks into that ER going forward. Dr. Halsey's insurer settled separately. His malpractice insurance rate increased. His hospital privileges were reviewed, resulting in an 18-month period of supervised practice for abdominal complaint cases. These are not the consequences of a story where a villain is destroyed. They are the consequences of a real case, modest and imperfect and real. I returned to teaching 8 weeks after the surgery, which was 2 weeks past what Dr. Flade had estimated, and 3 weeks before what I'd feared at my lowest point in the hospital. My first day back, Brigitte met me in the parking lot and walked me in without making a production of it, just appeared at my car door and said, "I've got the first period covered if you need a minute." And I told her I didn't need a minute, that I'd needed to be back in a room full of teenagers arguing about the causes of World War I since approximately day 3 of my recovery. She laughed. We walked in together. The scar from the surgery is below my bikini line and has faded to a thin white line over the past year, the kind of mark that's visible if you know to look and invisible otherwise. My abdomen ached for months after the surgery in the intermittent, unpredictable way of a healing internal wound, and I still occasionally feel a tightness in the area when I run, which Dr. Flade says is scar tissue and is normal and may or may not fully resolve. These are the things that don't appear in settlement documents and that the legal process has no mechanism to address. The way cold weather makes the scar site ache slightly, the way I have not been able to walk past an ER entrance since without a very specific feeling in my chest that I am still learning to name. I did something 6 months after the settlement that I hadn't planned, but that felt necessary when I did it. I requested a meeting with the patient experience coordinator at Millbrook General, a woman named Florence Abu Bakar who had been in healthcare patient advocacy for 16 years, and I went in and told her my story directly. Not the legal version, not the settlement version, but the version where I sat on an exam table in my shoes and tried to stand and felt my right side flare and knew something was wrong and was told I was dramatic. Florence listened without interrupting for 25 minutes. Then she said she wanted to share my experience anonymized in the hospital's internal quality improvement newsletter and asked if I would consent. I said yes. She also asked if I would be willing to speak to a group of ER residents, not about the lawsuit, not about the legal outcome, but about what it was like to be dismissed as a patient. I said yes to that too. And I stood in a conference room 6 weeks later in front of 14 emergency medicine residents, some of them barely older than my students, and I told them about driving to the ER in the morning, holding my side, about the 1-minute abdominal examination, about going home with ibuprofen while an infection spread inside me, about the 2:19 a.m. phone call with the surgeon. I told them what I'd wanted in those first moments, which was not a diagnosis I'd specified or a test I demanded. It was a doctor who looked at me and heard what I was saying, and considered the possibility that I might be right about my own body. One resident, a young woman in the second row, who looked like she hadn't slept in several days, which may have been because she hadn't, asked me what I would have wanted Dr. Halsey to do differently. And I said, I would have wanted him to sit with the uncertainty instead of resolving it in his favor. She wrote that down. I hope she still has the notes. I've thought a great deal about Dr. Halsey in the years since, which is not something I expected. Not with anger exactly, though the anger was real and I don't diminish it. More with the specific sadness of understanding that the failure that nearly killed me was not, at its root, spectacular or unusual. It was common. It was the ordinary failure of a system that processes too many patients too quickly and that trains physicians in ways that sometimes produce a particular variety of clinical arrogance, the belief that diagnostic uncertainty should be resolved by minimizing the patient's account rather than expanding the investigation. I'm not a physician. I don't pretend to understand all the pressures of an emergency department, but I was a patient who came in with 4 days of worsening right-sided pain, on a fever, and an elevated white cell count, and told the person responsible for my care that she was worried about her appendix and was sent home. The imaging that would have caught it cost $800. The surgery it would have prevented cost $94,000. The 4 weeks I spent unable to work, the 8 weeks I spent in careful and limited function, the months of intermittent discomfort that followed, those don't have a clean price. What I know is this. Every doctor I saw after Dr. Halsey from Dr. Ikurian through Dr. Falade through Dr. Nwosu to every resident who followed up during my inpatient stay heard me. They pressed on my abdomen and listened when I flinched. They looked at the trajectory of my symptoms rather than just the single point of the present moment. They treated my certainty about my own body as information rather than as an obstacle. These are not exceptional skills. They are the baseline of what medicine is supposed to be. I am alive because several people practice medicine the way it is supposed to be practiced, and I am in recovery from surgery that should never have been necessary because one person didn't. Both of those things are true simultaneously. I have stopped trying to resolve them into a single feeling. They are what they are, and I am still here, and sometimes that is enough.